and all present here. All the retina surgeons love the word retina, but they definitely dread the word recurrence. A 40-year-old patient presented to us a case of pathological myopia with diminution of vision in left eye since 4 days. The patient had undergone vitrectomy in the same eye 4 weeks back for macula involving inferior recurrent retinal detachment. On examination, the right eye was stable, the left eye vision was hand movements, she was pseudophakic, and she had a recurrent inferior retinal detachment in an oil-filled eye. So we took her up for surgery again. Standard 23 gauge ports were made, SOR was done. Inferior shallow recurrent retinal detachment was noted, but then our search for the retinal break began. We used the flute to see where the break is, but of no use. We couldn't find the causative break. We then used the help of PFCL to see if there is any sclerin, but we could still not note the break. So I'm here to present a novel technique of identifying occult retinal breaks intraoperatively. We used brilliant blue dye in 1:1 dilution via both the transcleral and the subretinal routes. For this transcleral route, we used the 26 gauge needle mounted on a 1 ml syringe in the dominant hand. The tip of the needle was applied to the globe tangentially and positioned where the depth of the SRF was greatest. The bevel was directed away from the retina to prevent iatrogenic damage, and enough dye was injected. This is a video showing the same. The needle is injected transsclerally, BBG is injected, and there you can see the plume of dye coming out into the vitreous space, and the break is at the margin of the CRA scar. For the subretinal route, you can use the commonly available cannulas, either the imported or the Indian ones. In this case, there's an inferior recurrent retinal detachment. The subretinal cannula is being used transretinally. BBG is being injected, and there is a plume coming out into the vitreous space. To delineate the break more clearly, we are using PFCL, and we can see the break at the margin of the PFCL bubble. So, occult retinal breaks form the second most important cause of recurrent retinal detachments. We can miss identifying these breaks because of various causes as enlisted here. Why is it important to identify occult retinal breaks? Because it prevents unnecessary destruction of viable retina through 360-degree laser and reduces the chances of recurrence. A subretinal BBG is particularly useful in high myopic patients. So through our literature search, we saw the description of dye exclusion technique, but all the larger studies used trypan blue. In our case, we used BBG over trypan blue because of the safer toxicity profile. The transcleral route has no unnecessary retinotomy, no destruction of more retina with laser, decreased possibility of recurrence because of the identification of break, and no requirement of subretinal cannula. But yes, there could be a possibility of hypertony, choroidal hemorrhage, or a retinal hemorrhage, or an iatrogenic break, but none were observed in the cases we used it in. So to conclude, BBG offers a better safety profile. Transcleral route requires no special instrument and no unnecessary drainage retinotomy. Subretinal route could be useful in high myopes with posterior detachments and significant scarring. Thank you.
Dr. Rajshekhar will be discussing.
Yeah, the search and efforts are good, but how many cases? This is the one case that you people have done, no?
Yes. So there are multiple cases that we do have multiple cases. I've personally assisted my chief operating surgeon, Dr. Mahesh Shanmugam sir, in almost 5 cases, and he's done it both ways, transclerally and transretinally, and we have not noted any particular side effect as such.
I think it requires a lot of skill, and the risk of hemorrhage is there. In case it bleeds, the whole thing. So maybe a safer way of staining and find. Basically, you're using the staining technique to find out.
Yes.
Now reaching the stain to the location is another challenge.
Yes.
So, any other comments?
In a myopic eye, I would also have my apprehensions on using the transcleral route.
Yes.
While I feel the retinal route is far more safer, but there you're creating a retinotomy.
Yes.
Then you see the unseen through the seen. something like that. So probably that might be in case the staining works very well.
Usually when we have used brilliant blue dye within the vitreous.
Okay.
So when you do it subretinally,
Yes.
would you do some animal experiments to study retinal toxicity, subretinal toxicities,
So in my literature,
before? Yeah.
so in my literature search, animal studies have already been done, which prove, even an ERG has been done, which proves that the toxicity profile of BBG is way more lesser than ICG, trypan blue, or even tricot. So it's there on my slide.
Okay.
Yeah.
Do you have a guard or something to stop it at the subretinal space, or how do you exactly guide? Because these are myopic eyes and the scleral thickness might be different from a regular eye.
Correct, sir. So it is mainly when we see the plume of the dye coming into the vitreous space, that is when we stop, firstly. And secondly, BBG dye per se is lesser, denser than water. So it gets flushed off from the subretinal space much more easily. So the concern of retention of the dye in the subretinal space is also much lesser. But yes, the eye should always be also in the vitreous cavity. As soon as we see the plume of dye, that's where we stop.